Bismillahirrahmanirrahim. Assalamu alaikum. Welcome to the second episode of our workshop on liver cirrhosis and Ramadan fasting. This session is designed for medical students, postgraduate students, and doctors, providing an in-depth analysis of real patient cases. We shall explore how fasting during Ramadan affects individuals with liver cirrhosis, discussing clinical outcomes, risks, and management strategies based on current medical evidence. Whether you are in training or clinical practice, today's lecture will enhance your understanding of this important topic. Let's get started. We shall discuss three case histories today. The first case history, I have titled this as Tailoring Fasting Recommendations. It's a case history of Mr. Ahmed, 52 years of age, with HBV-related compensated liver cirrhosis. CTP score A with 6 points. He's also having type 2 diabetes and mild hypertension. His current medications include entecavir for hepatitis B, metformin for diabetes, and amlodipine for hypertension. On pre-Ramadan visit, Mr. Ahmed consulted his physician a week before Ramadan to discuss fasting. He expressed a strong desire to fast, citing spiritual and personal reasons. And this is with most of our patients. You agree. His medical history and recent labs revealed stable liver tests, controlled blood pressure and blood glucose, no evidence of ascites, hepatic encephalopathy, or significant malnutrition. The physician explained the risk of fasting for cirrhotic patients, including dehydration, hypoglycemia, and potential metabolic stress. However, given Mr. Ahmad's stable condition, compensated cirrhosis, child score A, and strong motivation, the physician agreed to allow fasting with specific precautions. And these specific precautions were dietary plan. In Suhoor, that is the pre-dawn, he should consume high protein, low glycemic index foods, and plenty of fluids. And in the iftar, the post-sunset meal, he should use balanced meal with adequate calories, avoiding fried or salty foods. Regarding hydration, he suggested that Ahmad should drink at least 2.5 liters of water during non-fasting hours. Regarding blood glucose monitoring, he was advised to check blood sugar levels during fasting hours to prevent hypoglycemia. And to break the fast immediately if blood sugar fell below 70 milligram per deciliter. Regarding medication, he adjusted metformin timings to iftar and suhoor and encouraged skipping fasting on days when feeling unwell or excessively fatigued. During Ramadan, Mr. Ahmad adhered to his physician's advice. He fasted successfully for the first 10 days of Ramadan, reporting no major symptoms. Midway through Ramadan, he started experiencing fatigue and mild dizziness. Blood sugar checks reveal levels around 68 milligram during fasting hours. After discussing with his physician, he skipped fasting for 3 days to recover and increased his hydration during non-fasting hours. He resumed fasting for a few more days but chose to avoid fasting entirely in the last week of Ramadan due to persistent fatigue. Post-Ramadan follow-up of this patient. At his post-Ramadan follow-up, Mr. Ahmad showed no signs of liver decompensation. However, he had lost 2 kg during the month, and his physician emphasized the importance of maintaining adequate nutrition and hydration in the future. Lessons learned from this case history. Fasting is possible for selected cirrhotic patients. Stable patients with decompensated cirrhosis, child score A, may tolerate fasting under close monitoring and adherence to medical advice. Importance of flexibility. Patients should be educated to recognize warning signs, for example, dizziness, fatigue, hypoglycemia, and skip fasting when necessary. Physician's role in such cases, individualized assessment and ongoing support during Ramadan are critical, and the physician should be ready for it. Physician should encourage alternative religious practices for patients unable to fast safely, the fidya and the other ibadats. Takeaway message from this case history. This case highlights the importance of tailoring fasting recommendations to each patient's clinical status, educating them on the risks, and maintaining open communication during Ramadan. The second case history, and the title is Critical Role of Patients' Education and Proactive Management. This is a case history of Mr. Samir, 58 years of age, with HCV-related decompensated liver cirrhosis. Child score B with 8 points. His symptoms are ascites controlled with diuretics, occasional fatigue, but no encephalopathy. His medications include spironolactone and furosemide for ascites, lactulose for ammonia reduction, and carvedilol for portal hypertension. The pre-Ramadan assessment, Mr. Samir visited his hepatologist a week before Ramadan. He expressed a strong desire to fast despite his condition, citing the spiritual importance of Ramadan. During the consultation, the doctor explained that fasting poses significant risks due to his decompensated cirrhosis, including dehydration, electrolyte imbalance, worsening ascites, and hepatic encephalopathy. Mr. Samir insisted that he would monitor himself closely and break his fast if necessary. His doctor reluctantly agreed but emphasized that fasting was not advisable. A detailed plan was provided to minimize risks. Fasting during Ramadan, despite medical advice, as I said, Mr. Samir began fasting from the first day of Ramadan. He followed these precautions regarding dietary adjustments, consumed a nutrient-dense meal at Sohar, including high-protein foods, complex carbohydrates, and fluids. He avoided salty and fried foods to reduce fluid retention and minimize strain on his liver. He drank 2 liters of fluids between the iftar and suhoor as hydration strategy. He took diuretics after iftar to avoid dehydration during fasting hours. And the electrolyte dose was adjusted based on bowel movements to prevent encephalopathy. Complications midway through Ramadan. By the second week of Ramadan, Mr. Samir began experiencing symptoms, increased fatigue and weakness, dizziness and lightheadedness during fasting hours, reduced urine output suggesting worsening dehydration. On the 12th day of Ramadan, his family rushed him to the emergency department after he became confused and lethargic in the afternoon. Laboratory tests revealed significant electrolyte imbalance, hyponatremia, and hypokalemia, elevated ammonia levels indicative of hepatic encephalopathy. Mr. Samir was admitted and treated for hepatic encephalopathy in the hospital. He was rehydrated with IV fluids and electrolytes. Diuretics were temporarily withheld to stabilize his condition. Lactulose was adjusted to lower ammonia levels. After discharge, his hepatologist strongly advised against resuming fasting. The following points were emphasized. Religious flexibility. He was told the Quran exempts the sick from fasting, and Islam prioritizes preserving life and health. Mr. Samir could compensate by feeding the needy for each missed fast. That's we now call it fidya. Health risks. His worsening dehydration and encephalopathy demonstrated that fasting was incompatible with his medical condition. Mr. Samir agreed not to fast for the remainder of Ramadan and expressed gratitude for the care he received. Take away points from this case history. In decompensated cirrhosis and fasting, patients with decompensated cirrhosis face severe risks when fasting, including encephalopathy, dehydration, and metabolic imbalances. Fasting should be strongly discouraged in these patients. Communication with patient is very, very important. Respect patients' religious beliefs and provide compassionate explanation of the risks. Never be very rigid. Empathize the patients. Offer alternatives such as religious exemptions and charitable acts to fulfill spiritual obligations. Explain the fidya option. Monitoring. If a patient insists on fasting, ensure close follow-up and provide clear warning signs for breaking the fast or seeking medical care. Conclusion: this case underscores the critical role of patients' education and proactive management for cirrhotic patients during Ramadan. Physicians must balance cultural sensitivity with evidence based medical advice to protect patients' health. The third case history, and the title is Thorough Pre Ramadan Assessment and Patient Education. It's a case history of Mr. Khalid, 46 years of age, with muscle related compensated cirrhosis. With child class A, 5 points. His symptoms include mild fatigue, no ascites, and no hepatic encephalopathy. Medications he using: multivitamins and supplements for nutritional support, propranolol for mild portal hypertension. The pre-Ramadan visit. Mr. Khalid approached his doctor to discuss fasting during Ramadan. He was highly motivated to fast given his stable condition and spiritual commitment. During the consultation, his physicians performed a thorough evaluation, including liver function tests and nutritional status. Results indicated that his condition was stable. The risks of fasting were discussed, such as dehydration, hypoglycemia, and malnutrition. The doctor emphasized the importance of close monitoring and adherence to medical advice if fasting was attempted. The physicians approved fasting with specific precautions. The dietary plan given to him was: in Sohr, he should take high protein foods, eggs, yogurt, complex carbohydrates like oats, whole grain bread, roti, and hydration. In Iftar, he should use balanced meals with adequate calories, avoiding heavy, greasy, or salty foods. Snacks during non-fasting hours to meet caloric needs. Regarding hydration, he was advised to drink at least 2 liters of fluids between Iftar and Suhoor. And the medication adjustments: propranolol dose was adjusted to Iftar time to avoid potential hypotension during fasting hour. Regarding monitoring, he was asked to check frequent glucose checks during fasting hours and immediately cessation of fasting if symptoms like confusion, dizziness, or extreme fatigue occurred. Experience during Ramadan. Mr. Khalid began fasting from the first day of Ramadan. For the first week, he tolerated fasting well, experiencing only mild fatigue by late afternoon. Midway through Ramadan, around the second week, Mr. Khalid noted increasing tiredness and mild dizziness before Iftar. His family physician recommended the following adjustments: reduce physical activity during fasting hours to conserve energy, increase calorie intake at Iftar and Suhoor to prevent malnutrition, continue monitoring blood glucose. He followed these recommendations and resumed fasting without significant issues. Challenges in the final week. In the last week of Ramadan, Mr. Khalid experienced mild dehydration symptoms, including dark urine and dry mouth, slightly elevated liver enzymes during routine blood tests. The physician advised him to skip fasting for the remaining days to avoid complications. Mr. Khalid reluctantly agreed, choosing to perform religious compensations, that is, feeding the needy fidya instead. Post-Ramadan follow-up. At the follow-up visit, Mr. Khalid reported no major complications during Ramadan. a weight loss of 1.5 kg, prompting the doctor to stress the importance of maintaining nutritional status in the future. Lessons learned from this case history: fasting in compensated cirrhosis. Patients with stable liver function and good nutritional status can fast under medical supervision. Adherence to dietary guidelines and hydration is essential for avoiding complications. Symptoms like dizziness, fatigue, or dark urine indicate dehydration or early complications and should promptly cessation of fasting. So recognizing warning sign is very, very important. Flexibility and religious accommodations. Patients should be prepared to skip fasting if health deteriorates. Physicians should reassure patients that Islam allows flexibility for the sick. Takeaway points from this case history: thorough pre-Ramadan assessment and patient education are critical for safe fasting in cirrhotic patients. Physicians should provide individualized fasting plans and monitor patients closely during Ramadan. Recognizing when to advise patients to stop fasting can prevent serious complications. So, dear colleagues, dear students, please share your experience and thoughts on Ramadan fasting and cirrhotic patients. What's your experience? When a patient comes to you, how you advise, how you convince them not to fast, and when you allow them to fast. Please share your experience and thoughts in the comment section below, so we should continue the discussion onwards. Please let me know in the comments below, what do you want to be discussed in the next episodes. I'll try to address and answer all those queries and adopt the suggestions you will share with me. So I end here. Inshallah, in the next episode, we shall formally embark on our workshop of liver cirrhosis and Ramadan fasting. And in this section, we will have the introduction and background required for the subsequent episodes of the workshop. So till then, take care. Khuda Hafiz. I shall be waiting for your kind comments and suggestions in the comment section below. Take care. Khuda Hafiz.